Thank you. Thank you. Good evening, everybody. Glad to be here. When I got the call at first, I thought this must be a wrong number because the conversation was about healthcare reform and opportunities for entrepreneurs. And I thought, well, not so much. I mean, there isn't really that much, you don't go into healthcare to make a lot of money. But I did think about it a few more times and realized it wasn't a wrong number. I ended up with too many slides and had to cut half of them. So I guess that's a good thing. Okay, the instructions are the right one advances it? Okay. I have a question in the audience. How many people in the audience are nurses? Oh, I'm with my tribe. That's excellent. And how many people have a nurse in the family? Okay, you're all part of the nursing tribe. That's great. That makes my what's that?
That's good.
Yeah, makes my talk a lot easier because that's where healthcare is going, in my opinion. All right. As I said, I wasn't sure this was for the right audience, but in fact, I think there's a lot of opportunity, not just for nurses, but certainly for others. This is a picture, actually a clip to give credit, was in the Globe a couple of weeks ago after the elections, and all the ladies that spent tons of money and did not get elected. So that's not me, but I thought, it's a good visual, though. I think that's Carly from California crying in her soup that she wasn't elected. So I'm actually the one that usually gets mistaken for Martha Coakley. So I've got my own body double. It's not Carly, it's Martha Coakley. All right, so where are the opportunities? I have 3 areas I'd like to talk about. I'm so glad that we did not rehearse, but you mentioned the HIT piece because there's a lot of murkiness questions, but tremendous opportunity, lots and lots of churning and activity about HIT. So I'll spend probably half the time talking about that. Lots of opportunity in clinical areas, which are existing clinical areas, but the sands are shifting, things will change, and there's a terrific opportunity for new ideas, new technology to be applied to healthcare. And the Massachusetts models are fairly similar, so I'll just mention a couple of opportunities in Massachusetts and then finally talk all about some nursing opportunities. So, healthcare likes to think that we've always said, oh, well, we're different. We're not. That's why when I got the call, it's not. I must be the wrong number. We're different. We have a different business model. It's barely even a business model in some regards in terms of, hospitals. But in fact, we're finally catching on that we do need to be more like a business. And finally, hospitals are starting to catch on in terms of applying business practices like Lean and Six Sigma. And I'm actually taking a Lean class now and learning a lot. And we were arguing or jousting during the pre-conference conversation about, is there fat in hospitals? And I said, not really, but they could be leaner, though. There's probably some inefficiency, so we're parsing words there, but we're getting better applying some industrial techniques and opportunities in healthcare. So those of you interested in that kind of organizational improvement, whether it's Lean and Six Sigma industrial things, there's lots of room for that because there is some inefficiency that we need to cut out. In terms of, was mentioned the federal money, huge amount of money, tremendous amount. So the vendors are all doing the happy dance now, because there's so much opportunity for them to, with their existing clients or to develop new clients and to try to bridge and develop new products and bridge between systems and make things happen. It's almost too big to talk about. It's like a 3-day conference, so I won't go into the details on what the ARA funds do in terms of providing that money for the high tech, but suffice it to say, these numbers are the Massachusetts numbers. The federal numbers. It could be as much as half of this, so it shifts all the time. So I think the last estimate was a little bit less than like 44 billion. It might be 25 billion, but still pretty good in terms of opportunity. This is the Massachusetts numbers. So Massachusetts, you're talking about $1.23 billion of opportunity, incentives that hospitals will get back to them. Hospitals, providers, CHCs is community health centers for implementing meaningful use and other standards. This is the Medicare and Medicaid incentives. They're balanced out there, and I gave full credit to those who created this, which is the Mass Health eHealth Institute and Mass Technology Collaborative, doing huge work. So lots of good work going on, but in terms of how it actually happens when the rubber hits the road, there's a lot of work to do there, a lot of opportunity, and not just for sort of development entrepreneurs, but even just for career paths. If I could do it over again, I think I would have gone down the path of maybe nursing informatics or healthcare informatics. Really exciting when you're marrying. I get some nods in the audience there. Yeah, when you're marrying sort of the cool clinical jazzy stuff with the techie stuff. So I think that's a terribly exciting field for individuals' careers, or the bigger picture of what that work is about. So. I could go on forever about that. And it's valuable. I mean, it's not just a tech thing, a plug and play, something you plop in a hospital, doctor's office, community health center, but it really adds value to healthcare. I said we've been a little bit anachronistic in applying technology to some of the things we do. It's like to call the patients at home and that sort of thing. There are things we could do better to improve care, to bridge care across the continuum. So there's some examples here. These are all taken from some an ARC grant, the Agency for Healthcare Research and Quality, some federal money that went into a grant programs that were called Transforming Healthcare Quality Through Technology, the TH-QUIT program, supporting healthcare implementation. And these were all, funded and completed projects. And it's tremendous to see the things that you're thinking, these things don't happen already, or we don't have these tools and these technologies to bridge these populations and make this stuff happen. But this isn't even the tip of the iceberg. This is like a couple little things that got done with a little bit of federal money. But there's so much more of this that can be done to not just advantage an entrepreneur, but to actually benefit patient care. So that's the angle I would like to emphasize on that. Okay, so then shifting out of the HIT world, where obviously hospitals and others will be tremendously, incentivized to do the right thing, build these systems, make it connect, meet the definition of meaningful use, which we were all, hanging by a thread for how long? Months and months, a year, waiting for what is that definition? What's meaningful use? A lot of cartoons there, but there will be great incentives and investments going on in hospitals. So then moving on to some of the things that Don was mentioning, where things shift, and I really appreciate that Venn diagram of what's in what bucket, and I didn't like to see really where hospitals were so much, but but we're aware of it. So mostly on the penalty side. So this isn't an expenditure like the HIT piece, but this is a savings, like sucking this money out of the system, out of the hospital's pockets. And some would argue, well, it's about time. You need to get more efficient, do the right thing, put the care in the right place. So there's a couple of years where hospitals get some data and they're told, improve your readmission rates or else. So that's a couple of years of kind of the nice, that Proud Mary song. We start out really nice, and then they get rough after about 2 years, and you start facing these financial penalties. And the financial penalties are so severe, they're not just on the population which you did not manage well, and they had readmissions. It's on the hospital's entire Medicare population. So those numbers, 1% of, or -1, -2, -3% of millions is a lot of money, and it adds up to, $7 billion. So that's part of that. I think you said $160 billion. The hospital said, Rich Umdenstock, the president of the American Hospital Association, said, sure, we'll contribute, we'll help out, we'll try to not readmit people so much, preventable readmissions, and this is where some of it comes from. So how do you make this stuff happen? We don't know. It's sort of, I hate to admit it, but it's a huge part of healthcare. It's probably 20% of hospitals' admissions. That's a very general number, applies very differently in different settings, but so that's a lot of room, a lot of change that we have to make, a lot of system changes to squeeze that stuff out of the system. So we definitely need more tools to do that. We have a couple there's things going on. There's some great research going on by Eric Coleman and Mary Naylor and many others who have found these new models, but hospitals, healthcare, communities are kind of like cement. It's really hard to change the models and get those connections to work. So this work is going to tie really closely with HIT work, to bridge the where the patient goes, the record needs to go to provide the information in a timely way to prevent their readmission. But there's great opportunity. I love flipping through some of my trade journals and seeing all the cool things that people are inventing. To help patients do the right thing, participate in their care, stay at home or stay out of the hospital, get the care in the right place. So huge opportunity there. Where does the money come from? We're definitely going to redesign care. well, we hope we've got some federal motivation, but that could, possible things might change, but things are shifting now. CMS also is going to be paying for value and not volume. So those are changes in hospital and other provider behaviors. These are some examples of those projects. I won't go into them in detail. The little ones at the asterisk there, those are things happening in Massachusetts as well. Continuing care hospital model, patient-centered medical homes. There's a lot of grants going on. Many, many practices. I forget how many, but it's 80-something in Massachusetts just got some money to become patient-centered medical homes. And that includes they're buying two things. They're buying a better HIT system if they don't have one, from something as minimal as a registry to something more complicated. And they pretty much, for lack of a better word, buying a nurse, a case manager to bridge the care. So there's growth in the non-hospital sector in that kind of work. So, as I said, I keep coming across there's all these new real apps, like include on the phone. They're being developed for some of these things, and it's sort of like the sky's the limit in terms of, I think, chronic disease management was in your middle bucket there, I think, in terms of, sort of stable or opportunity. The population is getting older. The chronic disease burden is getting heavier. Lots of opportunity for managing those diseases. I mean, there are programs now, but they're sort of workplace-based, and they're very small applications. And so far, the research that I've looked at, a lot of them fail as soon as the grant money runs out. Everybody goes back to the normal behavior, and then people stop taking care of themselves. Way beyond the talking pill bottle, we're talking all kinds of things that will make a difference, and to create the feedback loop to get patients more engaged. We talk about patient engagement all the time. What is that? I don't know. But some of them will, and certainly a younger generation, a different generation, a more tech-enabled generation will be using other tools. Now, that will help people with the beeps and the buzzes and the reminders and the pedometers and all the things you can attach to your phone or whatever your applications are on to help you take care of yourself better. So lots of cool stuff going on right there. Actually, there's a program that those two groups I mentioned again, NEHI and Mass Technology Collaborative, have a big meeting on December 1st around tele-ICUs, applications that keep patients out of ICUs. I'm sorry, they're in the ICU, but they're being monitored by a more high-tech provider somewhere else. And so they can stay in their community, their family can visit them, they don't have to go to Boston, which some of the legislators in Massachusetts don't like, that we're so Boston and academic medical center centric, and that's why our healthcare costs 15% more than the rest of the country. So shifts are happening there, and there are many motivations. Where do we start with that? What is she talking about? Well, if you don't even know where to start, the number one cause of readmissions is congestive heart failure. So talk to your clinical people, get some stuff going on. There's huge opportunity there. Hospitals are motivated because they're not going to be getting paid for this very soon. So I don't know this company. I read about it. I just put the name out because I thought it was so cool. Very high-tech, implantable device, helps a patient with congestive heart failure stay home. Feedback loops to the providers to get the phone call, what to do, how to do it. So lots of stuff like that. And a million more diseases that can be done. And then I'm thinking, well, how about in a hospital? The hospitals have all these rules and don't use your cell phone and that sort of thing. I think there could be a lot more feedback loops built into hospitals as well, in terms of how, and as long as the networks work carefully and safely. Lots of more automatic feedback systems. More industrial applications than we have right now than the very low tech sort of stuff. All right, so that's the reform business and not getting paid and getting paid for less. I'm going to talk about nurses now. Our president says that nurses are the front lines of the healthcare system. Yes, I'm biased, so that's what I'm going to talk about. There's so many opportunities for nurses. All you folks that raise your hand, you're nurses. Are any nursing faculty here as well? Excellent. I want to just tell you all, rise up, do something about this. There's huge money in healthcare reform for prevention and wellness. Whose job is that? Besides the patient's job, that's nurse's job. And it's like it just fries me that others are taking over this work. So I think, I want to get you to sort of, realize that and rise up and do something about it. Change the Nurse Practice Act in Massachusetts so you're not like under the thumb of other licensees, and do this kind of work. Huge opportunity. Patients deserve a chance to stay at home when they can, to be cared for across the continuum, and to have time to invest in their own wellness and prevention. So that's my political spiel on opportunities for nurses. Many, many more. I'm afraid I'm running out of time here, so I'll talk faster. But there are great opportunities. I'm happy to talk to the nursing faculty or department more later, because a lot of this work does belong in that profession. And then thinking about the entrepreneurs are going, well, what about me? Well, all those applications, how to make this stuff work, those applications are necessary for the connections, the feedback loops. So in all kinds of settings, and which are designed to keep people healthy and well and in the right place. Not just, I'm very hospital-centric, of course, but we're talking about communities, schools, wellness centers, and there's also many incentives in the federal bill for workplace wellness, and some of those apply to, there's about $200 million for workplace wellness for employers with less than 100 employees. So small businesses are going to be looking to access, tools and things they can use to improve the health of their employees. One of the better models I've seen in Massachusetts is EMC Corporation, and they have a website. Their employees, voluntary, can go in, do a health assessment, decide what they want to do, if they want to participate, how to keep themselves better. They get some incentives for taking care of themselves, and whether it's diet, exercise, lifestyle changes. So there are ways that employers as well can bring down the cost of healthcare and the premiums that they're paying as an organization. So I think there's huge opportunity for wellness programs to be sold to employers and small employers that need to know, how do I do this? How do I make it happen? So, and I think that's a pretty cool thing, because you're also making people better and healthier. So how good would that feel to be doing? Other work for nurses and others in transitions in care to get over those penalties and help people stay at home, and some other miscellaneous kind of opportunities. Nurse managed health clinics. I mean, that's sort of my vision. I want to see in my town some old building rehabbed or new building go up in my dinky little town, and it's going to say, nurse managed clinic. Come here for excellent quality care by someone that listens, takes the time, is connected to the rest of the health system through a health information exchange, keeps you well, answers your questions, and there's 24/7 availability for your questions to keep you out of the emergency room. Right now, some physician practices, not their fault, there aren't enough of them, and they don't get paid for working after hours, and they say, go to the emergency room. A report came out this morning, some of you heard about it on NPR, and it said, I think it was, I forget which group, so I won't misstate it, but a big report came out in Massachusetts by Massachusetts Group acknowledging that we're fabulous. We have 97% insurance coverage still. The nation's aiming for the 95. We hope we get there. And it hasn't made one dent in the emergency room volume. In fact, it's gone up. Wow, I've got insurance. I'm going to the emergency room now. I don't have to, pretty good. I can get stuff. And, if they call their physician or the other provider, they're told, well, I can see you in 2 weeks for that really bad sore throat you have. So they go to the emergency room. So lots of opportunity there for those nurse-managed clinics. So I hope that I see some of you in about 10 years in my town with the big neon sign, or maybe something nicer than neon, but a nice sign. So that's my vision for healthcare. Connected health information exchanges, better focus on prevention and wellness, lots of opportunity for folks to get into that business. I see nurses everywhere. That's sort of what I see, and I hope that you do too, and I hope you see lots of opportunity. Thank you.